Hello and welcome to Health Professional Radio. I'm your host, Neil Howard, and I'm real glad that you could join us again. You know, most people who suffer a stroke aren't treated in time enough to prevent long-term and often permanent effects on speech, cognition, and motor function. Dr. Shahid Nimjee is joining us as a neurosurgeon at the Ohio State University Wexner Medical Center to talk about a study providing some hope for some unprecedented stroke recovery by retraining skin cells to become blood vessel cells. Welcome to Health Professional Radio, Dr. Shahid Nimjee, and thank you so much for taking the time.
Thank you for having me.
Now, of course, I did mention that you are a neurosurgeon there at the Ohio State University Wexner Medical Center. Give our listeners a brief look into your professional background, and then let's talk about this groundbreaking study.
Thank you. Briefly, I completed medical school like most physicians have to, and then I subsequently went into neurosurgery, did a combined open vascular and endovascular fellowship, and since that time matriculated to the Ohio State University Wexner Medical Center, where I serve as the surgical director of the Comprehensive Stroke Center at the Ohio State University Medical Center, and also have a foundational and translational research lab focused on developing new therapies to treat patients with acute ischemic stroke.
What is a stroke?
A stroke is the result of inadequate amounts of oxygen to the brain that results in dysfunction for the patient and brain death, and death of the tissues of the affected part of the brain.
Now, you said lack of oxygen and blood, or blood and oxygen. It is specifically oxygen that facilitates a stroke?
You're correct on the former, in that you have a cutoff in blood supply, and as a result of an insufficient amount of blood getting to that part of the brain is deprived of largely oxygen nutrition that results in irreversible, or often thought of as irreversible, damage to the brain, and a functional effect of that part of the damaged brain to the body.
When a person suffers a stroke, there are issues with cognition, motor skills. Are stroke victims aware that they've suffered a stroke and some of the things that are going on are a result of that stroke, or are they in sort of a state of like dementia?
Yeah, great question. I think in the acute phase, depending on the extent of the stroke, patients are aware that something is not right. It will present as difficulty with speech. In fact, there's a mnemonic we use called FAST, which is face, arm, speech, and time, which is you have a facial asymmetry, you have a weakness or a dysfunction in your arm, your speech isn't as it should be, and time represents the need for you to call 911 and get to the nearest emergency room. And so those are the fundamental things that we tell patients to look for when they're having a stroke, and they really do manifest that way. With respect to the second part of your question, in terms of the cognition, that initial recovery from stroke, you hope occurs in the immediate short term, but when you speak to patients weeks, months, and even years after their stroke, they'll say, I just am not the same as I was before. And that's what we have found when we look at long-term effects of stroke. We see things like cognition, where they may be able to take care of themselves, perform all their activities of daily living, even balance a checkbook, although we look at that as a litmus test for cognition. But they'll say, I just am not able to focus like I used to. When I get tired, I feel like I almost have those stroke symptoms again. And those are hallmarks of that long-term cognitive dysfunction that you alluded to in your question.
You mentioned time as part of FAST. What is the time frame from the onset of a stroke to where a person could potentially recover quicker? How much time are we talking about?
That's a great question. So in stroke, there are two acute interventions or two acute therapies available. The first, which has been available since 1995, is intravenous TPA, which is recombinant tissue plasminogen activator. This is a drug that most of your listeners will know is largely called a clot-busting drug. There's a clot somewhere in the brain that is causing the stroke, and that if a patient arrives to the emergency department between last known well, which is the last estimated time the patient was known to be normal, between 3 and 4.5 hours, and they meet a certain set of criteria, they can receive TPA, which has been shown to improve outcomes in stroke, outcomes specifically being motor function, the ability to take care of yourself, to speak again, and so on and so forth. The second available therapy, which came and was approved in 2015, is in patients who have a blood clot in the brain part of their internal carotid artery, or the first segment of their middle cerebral artery or anterior cerebral artery, they can undergo something called a mechanical thrombectomy. That's where folks like myself, who are trained in going through the blood vessels, either by entering that blood vessel through the groin or through the wrist, can go up into the brain with catheters and pull the clot out, either with aspiration catheters or stent retrievers, in order to reopen the vessel. Those are the two acute therapies that are available. And in fact, the mechanical thrombectomy that I described is available up to 24 hours after last known well, and is shown that with the right imaging criteria can result in patients recovering much better than if they don't get that therapy.
Now, let's talk about this study that is offering some hope by retraining skin cells to become blood vessel cells.
Right. And so this study is groundbreaking on two fronts. One is that in a preclinical model of acute ischemic stroke, it showed that if you treat the animal 7 days after their stroke with this therapy, that they had reduced infarct volume up on MRI, which is one of the main imaging modalities we look to assess the extent of stroke, and two, demonstrated that that when we trained the mice or had the mice move around in a video model of motor recovery, that their activity was much better than those who didn't receive the therapy. The second part of this that's really important is that it sets the precedent that instead of relying on stem cells or a source of biological therapy from somewhere else, there's the potential that you can use your own fibroblasts, which are abundant in your skin, and use those on your own brain to develop into blood vessels and ultimately potentially improve your outcome in stroke. So while this is preclinical, it sets the precedent that you need nothing but your own body. And two, it represents a potential therapy that is not as acutely time dependent as the current therapies available, like TPA or mechanical thrombectomy.
When these retrained cells have been retrained, how are they introduced into the damaged brain tissue?
In our model, it was induced through what we call a subarachnoid administration. It's where you make a small hole in the skull and you just deliver them into the subarachnoid space. And we showed that delivery is successful, and that delivery of the fibroblasts resulted in blood vessel growth, reduction in infarct volume.
How similar was the onset of stroke in these test subjects to actual human onset of stroke, due to cholesterol, due to injury, whatever?
So you mentioned one of the greatest challenges that we have in stroke therapy, in that the difficulty and the challenges that stroke has faced historically is that it presents heterogeneously. Some patients have cholesterol and plaques building up in their vessel, and that's the cause of their stroke. Some people have a cardiac arrhythmia, and it flicks a clot from the heart into the brain. Some people have carotid disease that affects their brain. And so with a heterogeneous presentation in stroke, it's hard to capture in preclinical models a injury type that represents all stroke. So this particular one that we used was one where we just cut off blood to that part of the brain like we would in a large vessel occlusion stroke. And then when we remove it, that the brain is now reperfused like in a large vessel occlusion stroke. And so that represents, when we look at it, look at how patients are presenting, right now we're saying there's about up to 20% of patients present with large vessel occlusion strokes, whatever the etiology, cardioembolic, large artery atherosclerosis. So the model is an occlusion model, and it covers several etiologies of how you can obtain that large vessel occlusion stroke. So it's certainly applicable in how someone like me sees stroke on a daily basis. But to your point, it's not the biology of atherosclerotic disease induced stroke specifically, or large artery atherosclerotic disease and stroke, or cardioembolic stroke. It represents the idea that the brain's been deprived of oxygen by some kind of barrier, as we see in large vessel occlusion stroke. And then there's reperfusion after somebody like me recanalizes the vessel again, and now we deal with the subsequent injury.
Doctor, I do understand that this study was published in the journal Science Advances, March of this year, and there will also be a link in the segment description when we publish. Where else online can our listeners go and get some more information about stroke in general, about the Ohio State University Wexner Medical Center, and about this study?
For general information on stroke, the American Heart Association and the American Stroke Association has great generalized facts on how stroke presents, how to primarily prevent stroke from happening, what happens when you've had a stroke. And for those listeners, especially in Ohio and the surrounding states, that the Comprehensive Stroke Center at The Ohio State University Medical Center has resources available on our own websites that allow you to understand stroke as we see it at Ohio State University. Our leaders and doctors, advanced practice practitioners, and nursing, physical therapy, and occupational therapy and rehab to serve our community here and all patients that come to our institution that are affected with a stroke.
Dr. Nimjee, I appreciate you joining us here on Health Professional Radio, giving us this information. Thank you so much.
Thank you for your time.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Shahid Nimjee. He's a neurosurgeon specializing in open and endovascular neurosurgery at the Ohio State University Wexner Medical Center. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes. Listen in, download as SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.